Today is Forgotten Infection Friday, so happy Friday. And welcome back to Diabetic Files, where we talk about saving limbs, saving lives, and recognizing infections that don't wait for anyone. Today is another one, and it's called Ecthyma Granunosum. And I'm going to spell it Ecthyma granunosum, Gangrenosum. So eczema granulosum. And this is not your typical wound. This is not your typical ulcer. It's a lesion that tells you that the bloodstream is already involved. And I used to have a little trouble wrapping my head around it because they do associate it classically with Pseudomonas aeruginosa, but I was like, "What's the difference between that, Ecthyma Gangrenosum, and sepsis secondary to Pseudomonas aeruginosa?" But we'll get into that because that was the thing I was trying to understand, but it actually is quite different, okay? So what is Ecthyma granunosum? So the term ecthyma granunosum comes from the Greek word. It's two Greek words derived. So ecthyma means a deep ulcerative skin infection, and granulosa means tissue death or gangrene. And forgive me if I got that wrong. And the condition was first described in the late 1800s, but widely became recognized in 1897 when a French physician, Jean Derriere, published detailed observation of the disease. So for decades, a lot of physicians were frightened of this pattern. And patients will come in with these severe bloodstream infections caused by Pseudomonas aeruginosa and would suddenly develop these black skin lesions that rapidly expanded and became necrotic. And these lesions became known as ecthyma granulosa and were suddenly recognized as one of the most characteristic signs of invasive pseudomonal infection. So see, you can see where I'm like, I got a little confused. So ecthyma granulosum, what makes it different? So ecthyma granulosa is a severe skin lesion, most classically associated with Pseudomonas bloodstream infection, but there are cases that are not caused by Pseudomonas, okay? But it's characterized by rapid progression. So it progresses from a red macule to a pustule to a necrotic black eschar. And the central tissue, there's central tissue death due to the vascular destruction and strong association with sepsis and immunocompromised patients. So unlike, a diabetic ulcer that begins externally, right? This lesion, ecthyma granulosum, actually begins internally through hematogenous spread, which is through the blood. So what's the key difference? The key difference is that ecthyma granulosum is a specific skin manifestation of a severe pseudomonal aeruginosa infection, whereas Pseudomonas sepsis is a bloodstream infection that may or may not cause ecthyma granulosum, okay? So like it's ecthyma granulosum is a skin manifestation, okay? So Pseudomonas sepsis, the bacteria is in the bloodstream. It causes systemic inflammatory responses. Symptoms may include fever, hypothermia, not hypothermia, yeah, hypothermia, forgive me, low blood pressure, rapid heart rate, altered mental static, and organ dysfunction, right? But the skin may appear normal or not have non-specific findings. But with ecthyma granulosum, it is a distinctive skin lesion classically associated with Pseudomonas aeruginosa bacteremia and occurs when the bacteria invades the walls of the blood vessels in the skin, and that causes vascular destruction, thrombosis, aka clots, blood clots, and tissue ischemia as well as tissue necrosis. So how does Pseudomonas aeruginosa invades the blood vessels? You see why Pseudomonas is so interesting? It's quite a very intelligent bacteria. So the key pathology of this is that it causes vascular invasion, okay? So the Pseudomonal aeruginosa enters the bloodstream and releases exotoxin A, which inhibits the protein synthesis, elastase, I know I'm not saying right, breaks down the blood vessel walls, proteases, which destroy the connective tissue, and this leads to endothelial damage, thrombosis of the small vessels, ischemia of surrounding tissues, and full thickness necrosis. And this is why the lesion becomes black and gangrenous so quickly. So we're gonna go into the stages, right? The step by step. Remember, said it starts with the red macule. So let's do the ecthyma granulosum pathophysiology stage by stage, okay? So first it starts off as a red macule, and that's like 0 to 12 hours, right? So what you will see is this flat erythematous patch, may be painless, maybe mildly tender. But when you see that what's happening biologically, the Pseudomonas has already entered the bloodstream, aka bacteremia. The organism has localized itself into the small dermal vessels, the post-capillary venules, and there is early endothelial attachment and invasion begins. And this is where exotoxin A plays a role, okay? So exotoxin A, it inhibits elongation factor 2. That causes a shutdown of the host protein synthesis, and this causes endothelial cells to lose their ability to maintain the integrity. And this early inflammatory signaling begins, but no major necrosis as yet. So the vascular event is endothelial irritation and early vasculitis. So there's minimal leakage, which which is caused because there's just erythema, right? And the erythema, that's why they have this red macule phase. Next phase is it turns into this hemorrhagic bulla that takes 12 to 24 hours. So what you will see is a blood-filled blister that has increasing foliaceous discoloration. And what's happening biologically, this is the true vascular destruction phase. And the toxins that play a role is elastases. And so when you have ACEs, right, you think of enzyme, right? Because it's an enzyme. So it degrades the elastin in the vessel walls, the vessel fragility, and it causes vessel rupture. The proteases, which breaks down the collagen and the extracellular matrix, this helps the structural support in the dermis loses integrity, right? And then exotoxin A does continue in this phase. It amplifies the endothelial death and local ischemia. So in this key event, when we have the hemorrhagic bulla phase, the vasculitis and vascular leakage and vascular thrombosis are at play. And the blood escapes into the dermis, and that's why we have a hemorrhagic bulla that forms. And, a pathological hallmark of this stage is the bacteria is in and around the blood vessels walls, okay? So aka angial invasion. Next phase of this will be the black necrotic eschar. So that takes about 24 to 48 hours. See how rapidly it progresses? Less than in about a few hours to days, but hours mostly. So when you get to the black necrotic stage, what you will see is a central black/gray necrotic plaque surrounding erythema and induration. And what's happening biologically, this is the ischemic necrotic phase, necrosis phase. And this is complete destruction of the vascular integrity, thrombosis of the dermal vessels due to the endothelial injury and inflammatory cascade, clotting cascade that's going on. The blood flow gets cut off, so that causes and results in a tissue infarction. And the elasticase and the protease continues to digest the connective tissue scaffold and accelerate full thickness dermal death. And this key event will cause occlusive vasculopathy, and the tissue becomes this cutaneous infarct. And the hallmark will be this dry gangrene like necrotic center, but it's infection driven. You have to remember that too. Next stage is the deep ulcer formation stage, which takes about 48 to 72 hours after the formation of seeing that red macule. So what you will see is the eschar will break down or slough, and there will be this deep crater-like ulcer. Possibly, there might be exposure of the fat and fascia or muscles. But what's happening biologically, this is a structural collapse phase, and the necrotic eschar separates from viable tissue. The ongoing bacterial enzymes activity, the proteases liquefy the tissue planes. The secondary inflammation worsens tissue loss, and there's no viable microcirculation remains at that center at all. So the surrounding edges may be inflamed or infected. And this is no longer a skin infection. This is now a full thickness tissue loss due to vascular infarction. So in the end, eczema granulosum is not a spreading skin infection. It is bacteremia driven, exotoxin mediated, elastase protease fuel necrotizing vasculitis causing cutaneous infarction. So I hope everybody can wrap their head around that. So we already talked about why the tissue turns black. So does every patient with Pseudomonas sepsis get eczema granulosum? See, that's why I was wrapping my head around because I was like, what's the difference, right? Give me for hitting my microphone. So no, only a minority of patients with Pseudomonas bacteremia develop eczema granulosum. Can eczema granulosum occur without sepsis? Actually, yes. Although eczema granulosum is classically associated with bacteremia, there are documented cases where Pseudomonas directly infects the skin and causes eczema granulosum without bloodstream infection. Can ecthyma granulosum occur without bacteria? Surprisingly, yes. This is one of the most fascinating aspects of ecthyma granulosum. So, in infectious disease, they recognize it in two categories, I believe. Classic ecthyma granulosum, which is usually caused by Pseudomonas aeruginosa, but then they also have this category of ecthyma granulosum-like lesions that could be caused by fungal infections, most commonly mucormycosis. We did an episode on that. Candida, Aspergillus can actually also have eczema granulosum-like lesions caused by viral infections such as herpes, other bacteria, Aeromonas, Serratia, even MRSA, methicillin-resistant Staphylococcus aureus. Okay, and sometimes neutrophilic dermatosis can resemble eczema granulosum, but that are actually inflammatory disorders rather than infection. So, in our diabetic patient, a diabetic foot ulcer infected with Pseudomonas can remain a localized wound infection, progress to osteomyelitis, can cause sepsis, and rarely develop the lesions resembling eczema granulosum in a vascular invasion when that vascular invasion occurred. So the key pathology is Pseudomonas sepsis is bacteria in the blood causing systemic illness. But ecthyma granulosum is the bacteria destroying the skin blood vessels, leading to rapidly developing black necrotic ulcers. Okay? So that's the interesting pearl. It is ecthyma granulosum is essentially a visible sign that Pseudomonas has become so aggressive that it invaded and destroyed the blood vessels and not just infecting the tissue. It invaded. The vascular invasion is what makes it like a very feared skin finding when it comes to infectious disease and wound care. So, what type of patients get it? What patients are at high risk of this? Okay, it's mostly patients who are immunocompromised, neutropenic patients, cancer patients on chemotherapy, severe burn patients, ICU patients with sepsis, and occasionally diabetics with severe infection. Okay, so important to note that even though diabetes is a risk factor, it's not a primary driver. It's the immunosuppression that is the primary driver of triggering this. Okay, eczema granulosum. So, like I said, can you get eczema granulosum without the bacteremia, without the blood stream infection? So, bacteremic eczema granulosum, the organism travels through the bloodstream and seeds into the skin. The non-bacteremic eczema granulosum, the organism enters directly through damaged skin. So, example would be burns, chronic ulcers, surgical wounds, traumatic wounds, and these cause blood cultures. The blood cultures will be negative. So, what is the gold standard of diagnosing eczema granulosum? Because it seems very complex. So, tissue biopsy plus tissue culture. So, not just a wound swab, not by clinical appearance, but a biopsy, a tissue biopsy demonstrates the histopathology. And the histopathology will show necrotizing vasculitis, vascular invasion, thrombosis, dermal necrosis, as well as organisms within the vessel walls. And tissue culture will help identify the exact pathogen, the antibiotic sensitivities, and the drug resistant pattern. Why is a swab not enough? So a wound swab will help identify the colonizing organism, but only a tissue biopsy can actually demonstrate the hallmark feature of eczema granulosum, which is the invasion of the blood vessels. So the vascular invasion is the defining pathological feature of ecthyma granulosum. Do we do additional workup? Of course, you're gonna have to do blood cultures, obtain blood cultures before antibiotics are started whenever possible. You definitely will get a CBC. It may reveal neutropenia or leukocytosis, so either or, okay? ESR, of course, ESR and CRP, of course, are gonna be elevated in that case. It's a severe condition. You're pretty much septic. It's the blood bacteremic, I guess. And lactate, of course, useful if sepsis is suspected. Imaging, that's not for what's it called again? That's not for diagnosing. It just shows if the infection is deeper, right? So how is it treated? So, this is an infectious disease emergency. So treatment should begin immediately. They're gonna admit the patient, broad spectrum IV antibiotics. If the patient's already admitted, yeah, broad spectrum antibiotics. Historically, they use cefepime, zosyn, meropenem. There are some multi-drug resistant strains, so they may use the newer beta-lactam or beta-lactamase inhibitor combinations. And then susceptibility guided therapy. That's why we love us some infectious disease. They're credible. Next, you have to figure out what was the source of the bacteremia, right? What Find the source. So either if it's an infected catheter, if it's pneumonia, if it's a burn wound, if it's a diabetic ulcer, if it's a urinary tract infection. So most of the time, if there's extensive necrosis, most likely the patient will need surgical debridement. So they do surgical debridement when needed because you have to remove the non-viable tissue, and the infection will continue to progress if you do not remove the non-viable tissue. Then the doctor has to treat the immunosuppression. So you have to correct the neutropenia. You have to correct the uncontrolled diabetes. You have to correct or address the chemotherapy related immunosuppression. Okay. So eczema granulosum in a patient, let's say the patient has a diabetic foot ulcer, it's if the patient has a diabetic foot ulcer and developing ecthyma granulosum, right? This is not one of those don't miss it crossover scenarios, right? Like where you routinely look at it, but this signals suddenly that there is a systemic vascular invasion, usually Pseudomonas, aeruginosa bacterium going on. So this is a big deal. So how does diabetic foot ulcer become like the patient who has a diabetic foot ulcer get eczema granulosum. So the diabetic foot ulcer is the portal of entry if most commonly, okay, if it's a patient who has diabetes. So in diabetes, we already have the microvascular disease, which will result in poor perfusion. We already have neuropathy that causes delayed presentation because we don't have pain as our protector to tell us that something is wrong. Hyperglycemia, which impairs our neutrophil function. We already know that hyperglycemia plays a huge role in compromising our immune system, and biofilm heavy chronic wounds. So a colonized ulcer, often polymicrobial, forgive me, can shift into a true invasive infection. So like this in a common organized organisms in the setting, yes, Pseudomonas aeruginosa, Klebsiella. I Forgive me if I said that wrong. E. coli, MRSA, okay? MRSA, that's a less classic EG, but it can coexist. Now, the bacteremia develops. So the eczema granulosum is not just a skin infection. It requires hematogenous spread. That means through the blood vessels, okay? Or direct vascular invasion from a local infection. But in our diabetics, right, this happens faster when there's a deep ulcer. Let's say it's from to tendon or bone exposure, osteomyelitis present, if there is a delay in the patient's antibiotics, and if there is immunological dysfunction going on. Then the vascular invasion of the dermis and the subcutis. So this is the dividing step. Like we said, the Pseudomonas, it invades the small dermal vessels. And then that's where we see these exotoxins, exotoxin A, the elastase, the protease, join in and cause this vascular thrombosis, and the result will be ischemia, necrosis, and black eschar formation. And this is why ecthyma granulosum looks like this punched out ulcer, right? And when we think of punch out ulcer in wound care, we do think arterial, right? black center and surrounding erythema and volaceous rim. And then the systemic amplification is going on because once bacteremia is established, the new lesions can appear distant from the foot, okay? And the patient can deteriorate quite rapidly because this is becoming sepsis. So, why are our patients at high risk? We already mentioned why they are at high risk. You have to remember, okay, the immune dysfunction, impaired neutrophil chemotaxis, the reduced phagocytosis, the poor oxidative burst that's going on in the immune dysfunction when there is hyperglycemia, and that causes the immune dysfunction in a diabetic patient. Then the microvascular disease. We have to remember with that, it reduces the antibiotic delivery, and the tissue hypoxia equals bacterial proliferation. Now, we already know because this is classically associated with Pseudomonas. What does Pseudomonas love? Moist wound environments, okay? And if we have this moist, necrotic, low oxygen environment in our wound from our patient, yeah, it's Pseudomonas friendly, okay? Pseudomonas loves that, okay? They want to take the opportunity, take advantage, and run free. We, we don't want to cause that for our patient. And then delayed care, delayed presentation secondary to neuropathy, okay? So when it comes to a diabetic patient, ecthyma granulosum is more likely, even though rare, but still more likely when a chronic diabetic foot ulcer transitions into a deep tissue infection plus having bacteremia. What would it look like in a diabetic foot ulcer? The red flags would be this rapidly evolving necrotic ulcer, black or gray eschar, so it's going to be this burnt out look, severe pain or paradoxical minimal pain, okay, with a neuropathy, this volaceous halo around the ulcer, bullae or hemorrhagic vessels, and then soil illness like fever, hypertension, okay? So the key distinction is ecthyma granulosum, this is vascular necrosis with bloodstream invasion. But a diabetic foot ulcer infection just it will stay localized, okay? And we already know intervention, you're going to most likely hospitalize the patient, blood cultures, you already know times two, consider bone culture if osteomyelitis is suspected. They, like I said, the empiric IV antibiotics are cefepime. They even use vancomycin, azosin, and vanco. Sometimes they add meropenem in MDR risk patients or amikacin. And then source control, okay? So, like I said, they're going to debride, urgent debridement of the necrotic tissue. If it's their abscess, they're going to drain it. If there's osteomyelitis, surgical debridement. And if there's ischemia, of course, you could definitely need vascular evaluation urgently. And imaging, we already know MRI will help us see the osteomyelitis as well, a CT if there's gastrics unsuspected, and vascular studies, so ABI, TBI, and duplex, okay? And no matter what, we're gonna need infectious disease on this case, okay? This is their realm. We need them, okay? So, multi-drug resistant organisms are quite common in this situation. So, antibiotic escalation might be needed, okay? And then, definitive therapy once the organism is identified, okay? So, they will confirm it through the tissue biopsy and the tissue culture and see what antibiotic is recommended. And then afterwards, they're going to need wound management after stabilization, might even need serial debridement, might need negative pressure therapy, moisture balance, offloading, glycemic control, optimization, of course. But you have to remember the one thing about ecthyma granulosum is not just a wound infection. It is not. It's a vascular infection of the skin caused by bacteremia until proven otherwise. And this in diabetic foot patients, that distinction is what separates limb salvage versus rapid systemic decline and amputation risk. So, what are our differential diagnoses when it comes to this? Okay. Definitely, you're gonna think necrotizing fasciitis, diabetic foot ulcer, pyoderma granulosum, vasculitic ulcers, calciphylaxis, and brown recluse spider bite even. So always have your differentials as well, okay? So what could it be mistaken for ectodermal granulosum can be mistaken for diabetic foot ulcer? Yes, but the key feature is onset of diabetic foot ulcers are usually slow. Ectodermal granulosum is rapid, hours within days. You have to remember ectodermal granulosum is through a hematogenous infection spread, okay? and that systemic signs are almost always possible, and there's multi-site possibility when it comes to progression of it. So, how do we prevent eczema granulosum? Because it usually is a complication of severe infection, and prevention focuses on early recognition and treatment. So, prevention principles will be control the diabetes aggressively. Hyperglycemia impairs the neutrophil function, like we said, chemotaxis, and phagocytosis. Treat wounds early. Do not ignore any increasing drainage, necrosis, new pain, or malodor. Do not just brush it away and be like, oh, you'll be fine. Absolutely not. Okay. Just don't do that. Identify if the patient is immunocompromised, high risk patients, like we said, severe neutropenia, advanced malignancy, organ transplant recipients. Okay, you have to remember they're immunocompromised because they're on steroids as well, right? Because they anti rejection and chemotherapy patients. And obtain cultures early, okay? Especially before the patient becomes septic. That would be very helpful, okay? And escalate quickly. If there's black tissue plus systemic symptoms, should never be treated casually. That's a big deal. So, eczema granulosum is merely not a skin infection. It's a warning sign that the pathogen, most classically, pathogen for this one is Pseudomonas aeruginosa, has breached the body's defense system and began attacking the blood vessels themselves. Ecthyma granulosum, not ecthyma granulosum, Pseudomonas aeruginosa, like I said, this is a very bold ostentatious bacteria. It is not a quiet one, okay? Very loud, boisterous, just wants to be known and takes over. Like you give it an inch, it's going to take a mile. That's what Pseudomonas does, okay? And a clinician needs to recognize, like, let's say the red macule that it starts with. If it becomes a black eschar, if you recognize that, we can help save the tissue, okay? The eschar could develop into septic shock. You got to recognize that so we can help save the limb, okay? But the essence of limb salvage is see it early, culture correctly, treat aggressively, and never ignore a black lesion that seems to appear out of nowhere, okay? Because ecthyma granulosum is one of those conditions that remind us that not every black wound is a wound. Sometimes it's a systemic infection speaking through the skin, okay? And in diabetic foot care, the danger is assumption, okay? And recognition of what it is the win-win for you and for the patients, okay? Because when we recognize things early, we don't just save a limb, we save a life. And this is Diabetic Foot Files. I'm Dr. G. This is Forgotten Infection Friday, and take care of your feet because they take care of you.